Namaskar, dear viewers, and a very warm hi and welcome to everybody. So today we have a very important section, that is VA ECMO. We know arterial ECMO, and basic principles will be taught in this lecture. So the speaker today is a distinguished faculty, Dr. VIVEK Gupta sir. Sir is consultant cardiac anesthesia and intensive care. He's an ECMO physician at Dayanand Medical College and Hospital, Hero DMC Heart Institute, Ludhiana, India. He is the chairman, Research and Ethics Committee, SWAC also, and he was a past president of the ECMO Society of India. So I think it's going to be a very informative lecture because he will be covering the basics of ECMO, and many of you are early in your career and many of you are students, so it will be very informative with ECMO becoming more and more prevalent and the use being widespread now. Over to you, sir.
Thank you very much, Dr. Tapesh, for a kind introduction. And I'll just share my screen. Is my screen visible?
Yeah, but the slide is not come yet.
Yeah, it has come.
Yes.
Full screen?
Yes.
That's fine. Thank you. So, in the recent past, almost in last 2 decades, ECMO has gained significant popularity. This was after this very popular Caesar trial, and there was H1N1 pandemic, and we all know that after COVID pandemic, probably everyone knows about it. And definitely for AIDS, it was VV ECMO. But if we talk about a VA ECMO, probably when ECMO initiated, when cardiopulmonary bypass was started, probably the concept of VA ECMO actually initiated at that time. Because it is nothing but a type of cardiopulmonary bypass, though it is not homologous to cardiopulmonary bypass, because there is a basic fundamental differences in the VA ECMO and the cardiopulmonary bypass. But the basic mechanism remains the same. So what we do here in the VA ECMO, we take the blood from the major vein, and after and oxygenator, we push back the blood to the major artery. And this is what is, by definition, is the VA ECMO. So when we talk about the VA ECMO, it provides both respiratory and hemodynamic support. Means it is supporting heart as well as lung. And where it is required, when you need to support, when cardiac functions are compromised, and you need to support the heart temporarily, and it's possibly a reversible one, or we'll be discussing that what can be the destination. So basically, it is never a full support like we think in the cardiopulmonary bypass. This is the partial hemodynamic support, roughly around 60 to 80% of the actual cardiac output. And definitely it improves the perfusion and oxygenation and helping to remove the carbon dioxide. So if you look at the basic structure, a blood is taken from the major vein and it is drained very commonly in the ICUs from the femoral vein, passes through the centrifugal pump, then it comes passes to the oxygenator, where the help of oxygen gas blender, gas exchange takes place, and then oxygenated blood is being pushed back to the major artery and very commonly to the femoral artery in the ICU. So you can see the complete structure. Blood is being drained, and you can see here the blood is passing through, though its pump is not the centrifugal pump, which is very commonly used for the ECMO support. This is the roller pump. And here you can see there is some bladder, though it is not a routine thing in the ECMO, but sometimes people use it. Then it is passing through the membrane lung, and it's passing through the heat exchanger so that the blood temperature is being maintained, and then it is pushed back to the major artery. So what it does, it provides almost 60 to 80% of the predicted resting cardiac output, and it is dependent on the preload, afterload, and how much flow we want to, and flow we adjust with the help of RPM, revolution per minute of the machine. And definitely depending upon the which size cannula we have placed. We must remember that the centrifugal pumps are the preload dependent and they are afterload dependent. load starts. If there is a preload is less, so the flow will drop on the same RPM. And if the afterload is very high because of vasopressors or so many other factors, so the flow will drop. Basically, we want to target a 50 to 70 ml of per kg per minute of flow in any adult patient. So how it affects the hemodynamics? What it does? It improves the cardiac output. Before ECMO, the patient is having a low cardiac output state. Pre-ECMO, patient will be tachycardic, but it will start optimizing. Mean arterial pressure improves. We target around 60. CVP, which is elevated because of the RV congestion, it reduces. Similar to that PCWP and left atrial pressure may remain high, LV may be distended in this. LV afterload, definitely it is going to increase because we do a retrograde ECMO. And LV ejection, which is severely impaired, it can further worsen if we increase the afterload. So this is why I said that afterload that needs to be taken care of so that we maintain the LV ejection during that. And pulse pressure, definitely once the LV recovers, it will start improving. So where this VA ECMO is beneficial? In the operation room, basic concept started with the post-operative, especially the pediatric population, where people are not able to come off cardiopulmonary bypass. And they used to put these patients on the extended cardiopulmonary bypass support, and that was the concept basically started for any low cardiac output state, which is leading to a progression to the multi-organ failure. High vasopressors, and patient is not maintaining, there is a worsening of the tissue perfusion, and that is leading to metabolic acidosis and lactic acidosis. Any acute ischemic cardiogenic shock or non-ischemic shocks like a septic myocarditis or any toxic myocarditis, viral myocarditis, pericardium cardiomyopathy, even cardiac arrest, that's ECMO CPR. If the conventional CPR fails, as patient is not responding to that, then possibly this is a candidate for ECMO support itself. But which cardiogenic shock? So if we look at the STY classification, probably the categories C, D, and E. In the late C, D, and E in the STY classification will be a candidate for ECMO support itself. So the indication, when we look at for a cardiogenic shock, any patient who is having acute myocardial infarction with a severe cardiogenic shock, arrhythmia, throwing arrhythmia, not responding to the conventional management, post-cardiac arrest patient, any patient who has some reversible cause and having a cardiac arrest, decompensated heart failure, where we can think of recovery in cases of myocarditis, pulmonary myocarditis, or post-cardiac shock. It can be as a bridge to transplant, bridge to decision, or bridge to any long-term assist devices. Post-procedural or peri-procedural, actually, any high-risk PCI should be maybe supported, or any complex ablations. Our patient is having a VT storm that, or we want to do any high-risk TAVI procedure. Any refractory conditions like a pulmonary embolism, where there is a cardiovascular collapse, drug toxicity, our patient is severely hypothermic, or if there is a patient is having a trauma and having cardiac. But whenever we are choosing our patient, we must remember that we need to rule out the contraindication, because you have to decide your strategy that the patient is having indication for ECMO because it is not responding to the conventional management. Conventional management means vasopressors, inotropic support, or other maneuvers to improve the cardiac output. If not responding, then only, but always rule out the contraindication. There are certain absolute contraindication like irreversible brain injury or severe anoxic injury to the brain. Absolute contraindication, patient is having a intracranial hemorrhage or bleeding, which is not compressible site, you can't stop. Chronic organ failures who are not the candidate, aortic dissection, severe aortic regurgitation, end stage malignancy, or patient is not giving consent for that. These are absolute contraindications. There are certain relative contraindications like advanced age. If the age is above 70, then it should be decided on individualized basis. If patient is having a severe peripheral artery vascular disease, then possibly we can think of central cannulation or some other maneuvers, coagulopathy, Our morbidly obese patients, where it is technically difficult, our patient is having a poor pre-morbid function, or unwitnessed cardiac arrest, when the cardiac arrest duration is more than 60 minutes, then definitely there's a contraindication. So what outcome we are expecting? The first thing we always think of, bridge to recovery, that patient will recover once the primary problem recovers. Or if not responding, definitely to bridge to transplant or some other supports in case like a renal support in cases of dialysable toxins or other issues. Bridge to another long-term bridge, and bridge to some time when you don't reach to any conclusion, probably you buy time for bridge to making decision. So how do you select these patients? The first thing you should think, what is the reversibility? The moment a patient, you are choosing a patient, what is the reversibility? Is underlying condition is treatable? Is the condition is acute and we expect recovery? And is it a viable bridge strategy? How long that shock was? Is it an irreversible shock? So you have to think time factor, that when to cannulate if cardiac arrest is prolonged. What comorbidities are there? Pre-existing cardiac condition. What is the neurological status? And ultimately, what is our goal of care? That um, um, what patient wants, what is their preferences, what is the family's understanding, and we have to clear them that what is our exit strategy. If not the working, the recovery, then what should be our exit strategy? That's possibly the most important thing we should keep in mind. So you can predict various scores are there for the cardiogenic shock. We can have a save scores to look for that. What's the possibility of survival? Or on the different scores, encourage scores or other scores. So poor prognostic marker if lactates are very high, are technically more than 10, but we have seen patients who are having a lactate more than 20 or 25 and they have survived. So possibly you have to, it's not the single value of lactate, but actually an overall condition of the patient that you need to keep in mind. If very low pH, age is above 75, no cardiac recovery in 72 to 96 hours. Reversible conditions, any myocarditis, witnessed arrest, there is no flow time is very short. We could put the ECMO very quickly, younger age group, and no significant comorbidity. So how we initiate that? This is important, that we must understand that when we are going to integrate a machine with a human being, we have to have something in between, and this is what the cannula is. We do the cannulation, and we take out the blood from the major vein. There's a femoral vein most commonly in the ICU setup, and we return back the blood. So VECMO can be either the peripheral one, what I'm talking about, these peripheral cannulations, or it can be central cannulation. So peripheral cannulation, either you can do by the percutaneous technique, by using cell dingers, or it can be modified cell dingers by making a cut downs, or it can be totally open. And central cannulations are always open. We have to do the sternotomy, so more risk of bleeding. When you see central cannulation, after sternotomy, you place the cannula directly to the aorta and to the right atria. While in peripheral cannulation, you are actually placing the cannula to the peripheral vessels. Most commonly, you can see here the peripheral femoral artery, femoral vein, and this is the distal perfusion cannula. So cannula, whenever you are choosing cannula, what you should remember that these cannula should maximize the blood flow and there should be minimum blood damage. And we must remember the Post's equation that longer the length, flow may be compromised, and if the radius is bigger, it is going to improve the blood flow. So there are multiple types coated with the heparin and so many radio opaque cannulas. So cannula characteristic we must know, and the size, there is always a good guide about the size, that depending upon the weight of the patient, what size of the cannula should be selected. But we must remember in the simplified manner that for a patient, adult patient, usually a venous cannula of 25 to 27 French is okay, and arterial cannula 70 to 90 French. So when we are choosing a cannula, many factors, how much flow is required, what site we are choosing for cannulation. You must do an ultrasound to see the vessel lumen diameter, and you must know that the cannula French size, that is related with the outer diameter of the cannula. And whenever you are choosing a cannula, you must think about the pressure drop, how much pressure drop, because the cannula is a tapering one. So when it is leaving the blood from the access or return, there's a drop in the pressure, and we must know that this drop should not be very high. So a drainage cannula, that's what the access or venous cannula, should be a multi-stage, usually 25 French, 60 centimeter, and this should be placed in the hepatic part of the IVC below the hepatic vein. And the return cannula is only single hole, end hole, 17 to 19 French, shorter cannula of 15 to 23 centimeter, and it should be placed in the femoral artery. And you can measure from the Ziphi sternum, or you always confirm it with the use of echocardiogram. And always look at the reperfusion cannula. That's usually a 7 or 8 French sheath we place to ensure the distal blood flow is established. Otherwise, the distal limb will be compromised, will have a compromised perfusion and may lead to a gangrenous change. The cannula size should be as large as possible. A small venous cannula will lead to a low flow, more negative pressures, and more complications. And if we are putting a small arterial cannula, then it may lead to hemolysis. So the technique, as I said, percutaneous, very good because you can do it quickly, minimal invasive, so least chance of bleeding because cannula itself make a good skin seal, and you are placing a distal perfusion cannula for preventing the limb ischemia. So we all know, I'm not going in detail, the routine Seldinger's technique, what we follow, but you can see here, these are the arterial cannula, the shorter one, and these the longer one is the venous cannula, and you can appreciate the many holes in the venous cannula. However, only one hole at the end will on the arterial cannula. And you have the multiple size of dilators, puncture needle, and guide wire. One thing you must remember when you are doing a percutaneous cannulation, never force any dilator, any wire. If it is not going freely, it means you are not at the right place. Why it is important here? Because it's a very wide bore cannula, and the dilators, if you pierce the vessel, if you puncture the vessel, you damage the vessel, then you can't put these patients on it. And it will be a failure. You will lose your patient. So be very, very careful. Never force dilators or cannula. So ultrasound guidance, it is a must because you understand that there is no peripheral vascular disease. You can measure the size and it is guided so that chances of injury or chances of vascular damage is minimal. Modified Seldinger's technique, where a surgeon opens the vessel and under vision, actually, they place a pulse string, and then as a Seldinger, in the method like the Seldinger, they directly under vision, they puncture the vessel. The benefit in those patients who are actually at the severe shock where the pulses are not palpable, or there is a severe vasoconstriction because of the high dose of vasopressors, there this technique is always useful. But this takes some time. So if the patient is having cardiac arrest, then definitely you go for percutaneous one, but otherwise you can use the modified Seldinger. So I cannot with the time because of time constraint, I won't show the video of this, but this is how they open the vessel under vision. They place the cannula with the Seldinger stick. Then comes the open technique where they just open all vessels, they place the cannula directly, or they use some graft. So this graft, so the distal perfusion is maintained and there is the least chance of distal limb ischemia. Besides femoral, axillary artery and IJV can be cannulated in those patients where the femoral is not possible. Here, patient can be mobilized. With the femoral patient, mobilization is a big challenge. And many complications like a north-south syndrome, which we'll be discussing shortly, can be avoided with the use of these axillary cannulations or other cannulations. Distal perfusion, I was talking that a distal limb perfusion cannula should always be placed in all conditions. So while limb ischemia happens, because the return cannula, means your arterial cannula, can obstruct the antegrade flow. And in low cardiac output state, you are giving a high vasopressor, so there is a severe vasoconstriction, and even patient may have the previous peripheral vascular disease. Patient is hypotensive. All these contribute to the limb ischemia. When you are placing this cannula, you can maintain a flow of around 200 to 300 ml per minute, and you can always monitor with a Doppler by comparing with the other limb or with the use of NIRS. So you look at the color, temperature, and capillary refill or Doppler checks, and compare with the other vessel. If this femoral distal cannula is not possible, you can place a retrograde cannula in the tibial artery. So how do we manage these patients on ECMO, cardiac ECMO? What is our goal? First thing, we must maintain a specific goal flow, what we want, how much flow we want to. And we always want that there should be ejections, LV ejections, so that LV distension can be minimized. So use the lowest RPM to achieve the desired flow with the ejection that will minimize the risk of hemolysis. How you understand? You look at the tissue perfusion, maintaining the mean arterial pressure, and you look at the lactate and bicarbonate. If the lactate is dropping, bicarbonates are improving, patient hemodynamics is fine, and patient is having a good ejection, probably that's the ideal flow for your patient. You titrate FiO2 for the goal saturation, and you CPS flow maintain as per the PSU. So what is the management principle? Manage your patient as normally you do for any post-cardiac surgical patient who has undergone any major surgery or any critical patient in the ICU. But what you add, your major addition is the ECMO machine. And you have to manage that this machine is not causing any harm to the patient, and we are maintaining an optimal flow so that we are achieving the best benefit from the patient. So what we do during an ECMO run, we monitor, we maintain the ventilation, we look at the anticoagulation management, hemodynamic management, fluid, hematological, nutritional management, and definitely we monitor these patients to prevent complication. We identify it early and we prevent the complication. So first and foremost thing is the team. There must be a dedicated perfusionist for running an ECMO program. Nursing staff should also be trained for it. The doctor should include a cardiac surgeon who can be helpful for your cannulation, anesthesiologist, ICU specialist, and definitely a dedicated ECMO physician. And other specialists like a nephro, gastro can be, whenever required, they can be, we can take them. What is most important that vigilant monitoring is key to success. And what we all monitor, the routine monitoring, what we do in ICU. But we must be vigilant. We should be more focused because this is associated with many complications which can be prevented by just regular monitoring, intense monitoring of these patients. So look at the ECG rhythm. Persistent tachycardia, if it is there, it means the flow is not sufficient, probably tissue perfusion is not available. Look at the mean arterial pressure. Always look at the pulse pressure. If it is less than 10, that is suggestive that there is a myocardial stunning and there is a more risk of LV distension. You have to look at your flow, ECMO flow. Is it too high? That is leading to LV ejections compromise. So look and make a balance of it. Maintain the temperature. Whatever, if the patient is not on spontaneous breathing, adjust the respiratory rate. Look at the urine out. This is a very good guide, a clinical parameter for adequate perfusion. If the quantity of urine is adequate, that means your perfusion is fine. The color of the urine guides you that there is no hemolysis. If there is any hemolysis, you will start looking at start seeing the pink color of the urine out. Then you look at the gas exchange. You look at the peripheral perfusion, you look at the SpO2. Whenever there is a patient is hypotensive, shock, then definitely it is not. You might not get an oxygen saturation. So you look at the blood gases and you look at the PO2. What is most important here to remember? If you are using a femoral VA ECMO, you must monitor the right hand saturation. Preferably, the right radial artery should be cannulated and you must check the blood gases. But if not, at least monitor the right hand saturation. Why it is important? Because the upper body is perfused by the right side, by the heart itself. In those situations, when the oxygenation is not adequate, the coronaries and the carotid may get compromised and their oxygenation is not adequate. When the heart function improves and they have the poor lung functions because of failure or development of any new problem or ARDS, or low oxygen adjusted on ventilator. So this leads to differential hypoxia or upper body sinus. So that needs to be taken care of. Look at the venous oxygen saturation. You have not placed the pulmonary artery catheter. Look at the venous oxygen saturation itself. That will tell you about the balance of oxygen delivery and consumption. Use of NIRS, looking at the civil saturation, capnography, and carbon dioxide, they can be good guides. So when which site you are cannulating, this is important that where the monitoring of blood gases or saturation should be done. If you are doing a femoral, right radial artery. If you are doing a right axillary, opposite side left radial should be checked. If left axillary, right radial should be checked. In central cannulation, no problem. You can do monitoring from anywhere because there is no risk of differential hypoxia. Common carotid, which is cannulated in the pediatric patients, so there is a more risk of stroke. There we look at if the right common carotid is cannulated, we look at the left radial. How do we monitor the ECMO parameter? Because monitoring ECMO itself is a very, very important to prevent ECMO-related complications. So you monitor your ECMO parameters on three aspects: accuracy of your ECMO, efficacy of ECMO, and safety of it. So if I talk about accuracy, you monitor the heart rate. Check your circuit hourly for any clot, air bubble, any leak. Look at the machine, what flow, what RPM you have set, what flow we are achieving, what is the sweet gas flow, and what is the ECMO FiO2 you have adjusted. Look at the oxygenator. You have to look at the pre-oxygenator pressure. There's a drop after the blood passes through the oxygenator. That's called as delta pressures. Those pressure, trend of those pressure needs to be monitored, and you should check the post-membrane blood gases to look at whether adequate oxygenation is taking place. Efficacy, you assess by clinical and biochemical parameters that your ECMO is working very well. Goal is to maintain adequate tissue perfusion with a minimal complication. So we look at the mean arterial pressure, we look at the lactate levels, correction of metabolic acidosis, reduction of the vasopressors, and we look at the mixed venous saturation. Safety, we look at the ECMO parameter like a pre-pump pressure. Most of the time, you have to look at the trend, not on the single value. Pre-oxygenator and post-oxygenator pressure, and you look at the delta pressure. To ensure that you are maintaining adequate coagulation by looking at a regular ACT check or APTT check, though factor 10A or other TEG or ROTAMs are, but in an ideal scenario, you have to have the economical run of ECMO. So having a very costly test, if not indicated, then possibly you can avoid. So looking at ACT and APTT is fair enough. Look at the platelets counts, because there is, when you are using heparin, there is a risk of hit, or even otherwise also there may be drop in the platelet count. You look at the CBC, that will tell you the hemoglobins or platelet tests. Check regularly plasma-free hemoglobin if you have any suspicion about hemolysis. You look at the LFTs, that guides you that bilirubins and liver is not damaged. If your cannula position is not correct, it might obstruct hepatic vein and your bilirubin may go high. Urine hemoglobin urea will guide you that there is a possibility of hemolysis, and you assess clinically and radiologically to ensure that everything is running well. To target a mean arterial pressure result around 65, you maintain adequate preload and maintain a mixed venous saturation 7, target a mixed venous saturation around 70%, and your target is to reduce the lactate less than 4. So you target a blood flow around 60% of the cardiac output, and normally 3.54 liter is sufficient. And once your flow is adequate, you start reducing the vasopressors, but you monitor the mean arterial pressure. Don't allow mean arterial pressure to drop drastically. And you may need ionodilator to ensure the cardiac contractility. You look a regular echo, and it's not a cardiologist. You must be trained as an ECMO physician to echo so that the basic echo you can understand, and you look at the cardiac. Sometimes challenging, patient may have hypotension. The possible cause, inadequate preload, maybe patient is bleeding, or there's a low hemoglobin, or sometimes the loss of pulsatility or cardiac contractility. So try to maintain the preload, correct hemoglobin, and sometimes this, because of surge induced by the ECMO itself, patient may require vasopressor. The major issue what I talked about is the differential hypoxia, that's called as north-south syndrome, or we call it as a Harlequin syndrome, in cases of peripheral femoral artery accessed, because the blood is mixed retrogradely. So it all mixing depends how much is the cardiac contractility. If in the initial phases, when it is very poor, the majorly this mixing is happening very close to the heart. But as the cardiac contractility improves, this mixing comes down, and the upper part of the body is getting blood flow with the heart itself. So if the oxygenation is not good, that can lead to cerebral and coronary hypoxia. This, you can see the mixing cloud. It all depends on how your the heart is pumping, and if it is heart is ejecting blood, So it will come down and the mixing will be taking at a very low. So how to fix the Harlequin syndrome? Increase PEEP at FiO2. Sometimes you reduce the ECMO flow itself, or sometimes you need to convert VA-ECMO to a VAV ECMO. If patient does not require ECMO, probably you can take it off and this all can be recovered. How do you manage the myocardial stunning? The incidence is 1.5 to 7%. It is reversible condition provided you address it early. So how do you identify when the pulse pressure is less than 10? Why it happens? Because there may be severe LV dysfunction, there is an incomplete venous return, aortic valve insufficiency, or sometimes with a left right imbalance. So when you detect it, how do you unload this? You can use the anodilators, dobutamine or milrinone. You can use the intra-aortic balloon pump, or sometimes you require a surgical LV venting by either in the cath lab, taking in the cath lab with atrial septostomy, or you can use impeller devices, or you can do a surgical venting. If tolerated, you can reduce the flow itself. That will improve the myocardial contraction. So when there is a myocardial stunning, it will reduce the LV ejection. There will be distension. It will be visible distension of the LV, dilatation. There will be MR, and patient will start having frothy secretions from the endotracheal tube. So whenever this situation is there, you should take all precautions. You should be acting early because this will lead to a more of the myocardial damage. So I have already talked about various methods of LV decompression. How do we ventilate our patient when a patient is on VA ECMO? The purpose is we want to give rest to the lung, though lungs are not a culprit until there's a failure or patient is having a concomitant ARDS, but still we avoid any lung injury or we avoid any lung collapse. So protective lung ventilation, 5 ml per kg of your plateau pressure should be less than 25, and you can reduce the FiO2 as well as 0.3 or 0.4. Or sometimes if the patient is otherwise fine, you might extubate your patient. Ultimate goal is extubation. So once the oxygenation is improved and blood gases are showing a good saturation, we can extubate these patients. How do we manage the anticoagulation? We look at the various parameters and we load with the 50 to 100 unit per kg unfractionated heparin, the most commonly used drug for anticoagulation, and we target a ACT of 160 to 180 or up to 200 in the VA ECMO, and we start infusion for it. We keep monitoring ACT most commonly, or at least once, twice or thrice in a day. You look at a APTT and you target a APTT of 60 to 70 seconds, or ACT of around 180. And then you start with the infusion. Sometime when patient is bleeding, or you need to look at what blood product needs to be replaced, then you can go for the TEG or ROTAM, and you monitor anti-10. If patient is having a hit or there's a problem, you can use bavloridine as an alternative. So it is getting very popular, but still in India, we commonly use heparin as a first line anticoagulant. Bleeding management, because this is a big challenge on the VA itself. So blood loss can be major bleeding, what we call it as, when the drop in the hemoglobin more than 2 grams, our blood loss is more than 20 ml per kg or 24 hours, our patient is requiring a significant transfusion. Fluid overload, again, it's a big challenge. Fluid overload and acute kidney injury can be a big challenge on VA ECMO, because in the initial phases of shock, we give a lot of fluid to maintain, and when we start initiate ECMO, because of the source response, patient require a lot of fluid. Because once patient is stabilized, because we know that with the fluid overload is associated with a high mortality, once patient is stabilized, we start maintaining the negative balance rather than pushing fluid, too much fluid. And we always assess the fluid status by looking at echo, stroke volume variance, or other dynamic parameters. Renal dysfunction, pretty common on VA ECMO, and the incidence of acute kidney injury is as high as 50 to 60%, and almost 30 to 40% of these patients who do not open up, they require some or the other form of CRRT. Usually, these patients, because of cardiogenic shock, they will have drop in the urine output. But once the cardiac output improves because of VA ECMO, these patients improves, but sometimes they require CRI. Sedation, usually once the patient is improves from the shock, you can start interrupting sedation and actually on the ECMO itself, you can make the patient awake if patient is otherwise comfortable and you can extubate the patient. Nutrition, as we do for any other critically ill patient. Same manner, we have to maintain the nutrition when the hemodynamics is permitting us, and we have to make sure that we are maintaining a good glycemic control by monitoring blood sugar and with a continuous insulin infusion. Complications common with all ECMOs, whether it's a VA ECMO or VV ECMO, chattering, very common that sometimes the volume is status is poor, patient is relatively hypovolemic, especially in the VA ECMO when they are bleeding. So patient's venous line starts moving, chattering. There's a jerky movement. So you have to reduce the RPM to manage this chattering. Hemolysis, the flows are very high. In those conditions, there can be hemolysis. You look at the LDH, it is very high. Plasma-free hemoglobin is high. So you have to look for the reason and you have to address the reason. Bleeding, I have already talked. Leg ischemia, you can see here, even if the patient is not given a adequate distal perfusion, you can see there's a dusky limb you can see on the right side, and that can that may itself become a challenge in the later stage. Patient will have a compartment syndrome, gangrenous changes, and it will itself become a septic source for a patient. So hemorrhagic complication can happen from anywhere, from cannula side, GI hemorrhage, intracranial hemorrhage, pulmonary hemorrhage, retroperitoneal because of cannula, or even because from the circuit. Thrombotic complication, there can be risk of circuit thrombosis. Even in patients, thrombosis can happen if the heparin management is not good, or sometimes patient develops a HIT type 2, and those patients can have this thrombotic complication. Neurological complications, again, incidence is pretty high on the VA ECMO because patient can develop an intracranial hemorrhage. Patient is on heparin, shock. When if the blood pressure is improving, they may develop an intracranial hemorrhage. So neurological assessment is something very, very important. You should assess many times in a day by reducing the sedation. And any point of time, if you have a doubt, you must do the CT scan to assess these patients. Acute kidney injury, I have already talked, and almost 30% patients who develop acute kidney injury, they progress to the stage 2 or 3 and they require CRRT. For fluid management, especially the most common indication is the fluid removal when the urine output is not good with the diuretic. Infection risk, again, most of the time you are putting these cannulas under tremendous stress, CPR is ongoing. So there is always a risk of infection because of the compromise situation. And you must ensure that circuit is uninterrupted. You are not pushing any blood or drug from the circuit. So you are not breaking the circuit every time. And minimal handling of the circuit. Whenever you suspect, because the common symptoms of sepsis, like a fever or drop in platelet or increasing WBC count, these are common with the ECMO. So it is very difficult to identify sepsis in these patients. Sometimes sepsis is only identified with a sudden drop in the preload or sudden requirement of the fluid because patient is having a chattering. So this can be the first sign in some patients. So whenever you are using antibiotic, dosing is very, very important because of there's a volume of distribution is very high in these, and patient is already having SIRS, maybe sepsis, and with the ECMO itself, the volume of distribution high. So dose adjustment, higher doses may be required, especially for the meropenem or other antibiotics. And it is preferable to have the extended infusion rather than actually giving a bolus dose. So how do we assess the recovery of the cardiac function? This can be assessed by looking at the improving hemodynamics, increasing pulsatility, so the pulse pressure becomes wider, in fact, reaches to 20 or more, the tachycardia settles. When you look at the echo ejection fraction, is improving, aortic VTI is more than 10, lateral mitral annular velocity is more than 6, and TAPSE is fine, right heart function it looks okay. Metabolic correction is there, lactate has gone down, metabolic acidosis is corrected, urine output is good if the patient is not on CRRT, and other markers, renal and hepatic markers are improving, and clinically also patient neurologically, other parameters are looking good. So we start weaning these patients. So when the patient meets with these criteria, we start weaning our patient from that. So it should be over a few hours, weaning sometime. Maybe you do wean and then patient does not improve or does show deterioration, you again escalate these your ECMO support. So whenever you are weaning, you must look at these echocardiographic parameter frequently. You reduce the blood flow 500 ml and you monitor this patient for next couple of hours. If patient remains stable, there is no tachycardia, there is no drop in the urine output, lactates remain stable, your echocardiography is showing ejection fraction above 25%, then you further go down and then you keep monitoring and you further reduce and you bring down your ECMO flow to the ideal flow that's around 1.5 liter for a adult patient, and then you start doing trailing. Trailing off means you have stopped the ECMO itself, but you have not removed the separated the ECMO from the patient, so that even in case of any drop in the patient's clinical condition, you can immediately escalate. But few things while weaning and trialing off, you must keep in mind that you must evaluate your patient very frequently. And we commonly use the bridge when we wean the VA ECMO and we are using a trial ECMO so that the patient is separated from ECMO. No flow is going to the patient. At this point of time, you must remember that when you are disconnecting, means you are separating it through the bridge, your ACT on both the side, patient side as well as on the ECMO side, should be good. Your heparin infusion should be a bit higher. You might need to start some inotropic support. You increase your ventilatory setting, do a serial echo, look at the blood gases and mix venous oxygen saturation. While weaning, echocardiography is very, very essential. You see that if there is a failure in the weaning, whether it's the right heart failure worsening or it's a left ventricular failure, what type of dysfunction is there, whether it's a systolic or diastolic, is there any development of the new regional wall motion abnormality, or there is some development of the mitral regurgitation, or there is some tamponade that is obstructing it, your improvement, or there is a hypovolemia. So all these needs to be evaluated during weaning. And if the patient is not tolerating the weaning, it means that this patient needs the escalation and next step to be followed. And this patients require reevaluation. First, reevaluate and rule out the causes which are treatable. This might be simple hypophosphatemia. This might be simple electrolyte imbalances or some tamponade. So if there is any reversibility you think of, otherwise you escalate your option with a long-term or durable assist devices like a left ventricular assist device, or sometimes patients require a 5 watts. And if not improving, then possibly can be a candidate for transplant. So you have to define in the beginning the goal of care, and it might change depending upon the clinical condition. Sometimes the patient has an intracranial hemorrhage and goal of care will change. Now you have to go on the palliative care in these patients. Probably you need to talk to the family and you have to de-escalate in those situations. So all these possibility can happen and you have to be mentally prepared. So to conclude, VA ECMO, whenever you are choosing a VA ECMO for a patient, first patient selection should be very good. You must look at the indication. Two things are important. Reversibility, if you feel that reversibility or exit strategy, and you have the highest support to the patient, because ECMO itself has so many complications. So if you are choosing ECMO as a first therapy, may not be a good option. Then peripheral VA ECMO, you must remember that it increases the LV afterload. So LV distension must be monitored, and if there is LV distension, significant LV distension, you must look at the unloading strategy. Whenever you are using a femoral artery as a VA ECMO, there is a risk of north-south syndrome or differential hypoxia. You must monitor the right hand saturation. Distal perfusion cannula should be a standard of care because it will prevent the distal limb ischemia. In spite of distal perfusion cannula, you must monitor your distal limb very carefully by looking at color, temperature, and pulse. If NIRS is there, then you must use it. Anticoagulation should be very important that you titrate your APTT 60 to 70 or ACT 160 to 180 If patient is bleeding, you might come down for some time on the lower side, but on VA ECMO, usually you don't stop your anticoagulation. If there is a hit, then probably you can switch over to the bivalent rating. Inotropic support, in the beginning when patient is on high vasopressors, reduce it gradually. Don't drastically reduce it. If you don't reduce it, it will increase the afterload. But if you reduce it rapidly, there will be hypotension and that can be detrimental. When you are weaning your patient, low dose inotropic support like amilrinone or dobutamine can be started. Your regular echocardiography should guide the recovery of the myocardium along with the pulse pressures, ejection fraction, VTI, and the left mitral aneurysm. Involve the full multidisciplinary team so that you identify the complication early. Be very, very cautious because the complication do happen, especially on ECMO, and you won't get time to manage those. So identify them early, prevent complication rather than you are managing it once it happens. Thank you very much. I'll be happy if you have any questions.
Thank you very much, Dr. Gupta, sir. Wonderful. And I think that was very essential and basic principles for all our young listeners, especially. So request the audience if they have any questions, please type your questions. So there's a lot of applause from one of our attendees. Thank you for the applause, Dr. Julius. So maybe I can just put up 1 or 2 points which will be of interest to everybody. So, Dr. Gupta sir, what is the main challenge you face in getting the patient out or in running the ECMO?
See, the most important thing that when patient is reaching to you, because what happens, uh, is still like a patient, we keep pushing vasopressors, we keep giving drugs to maintain the hemodynamics, we run behind the numbers. But these numbers are not important. What is happening to the tissue, whether tissue perfusion is maintained or not, that is important. So when patient reaches to you late, or sometime cardiac arrest, patient has a cardiac arrest, then it becomes a very challenge. So it is better you put the patient on ECMO on right time, because if the second organ has damage, suppose acute kidney injury, acute hepatic injury has happened, then the possibility of recovery is less as compared to the single organ. So patient selection at right time is probably the most important and big challenge. When we talk about ECMO itself, so when we are running ECMO, probably bleeding is a big issue in the VA ECMO itself. Even when you do the surgically or you do the semi-simultaneous technique, in percutaneous, this is not a challenge. Cannulation can be a big challenge because if you are trying percutaneous, these patients are severely vasoconstricted, so vascular injury risk may be very high. Then when you are running ECMO, LV distension, arrhythmias, or north-south syndrome, you should be very, very cautious for these things. You should be, in fact, extra cautious. You should always feel that this might happen, and that way you can prevent these complications.
Thank you for the answers. So then, how much of sepsis are you seeing? Is it a real problem for you in your programs?
It depends upon for what indication I'm doing. If you ask me, acute coronary syndrome with a cardiogenic shock is coming to me. Probably that may not be having a as good result as we have the aluminum phosphide. We have a survival of close to 70% for aluminum phosphide poisoning patient. Even they came late, almost 30% patient we actually converted to ECMO CPR. We have done almost 120 of aluminum phosphide. That in 25%, yeah, almost 20-25%. Around 30 patients, we actually did CPR, ongoing CPR while placing the cannula, and with a very good survival. So this all depends that what's the reversibility. We know that aluminum phosphide, these patients will recover in 4-5 days. But peripartum cardiomyopathy, good result. These viral myocarditis, good result. Post cardiogenic shock, good result. But yes, if the patient is coming with a cardiogenic shock and the collapse, then probably, if you go for early, because that is a running between the cardiologist and the ECMO physician, that they want to put a stent first, and we always say the door to perfusion time should be good. So these probably those selection we need to improve. Otherwise, our results are pretty good.
Great, sir. So, and about I think you said something about myocarditis patients, viral myocarditis. Anything you want to tell specifically? Do they behave differently? Anything specific on ECMO for these patients?
No, they take time. They take time. They take almost week to 10 days to recover. And even we have seen the patient's viral myocarditis during COVID. Two patients. In fact, probably that was, we could not report that, but possibly that was the first ECMO in the country itself we did. That we did the VAV ECMO in that patient. That lady, two patients we got. One we were able to save, other she died. Both of them had the travel history of travel from Canada to India, and it was January 2020. So that till that time, COVID was not so. We were not so much threatened about the COVID. They came with the viral infection to us after 15, 20 days after the illness from different hospital and landed up with the ARDS. To this lady, when I looked at first time, so they said VV ECMO because ARDS is there. So I said, okay, but family did not agree. Next morning, I got again call. And this time I saw that she is in shock. I said echocardiogram. They said, we have done echo, it is normal. I said, no, it doesn't look normal. We did echo, it was just 15%. And then we did the VA ECMO first, and then we had to convert it to a VAV ECMO in those situations, in that lady. The other guy, again, he had come from Canada, and we did this ECMO also in the January 2020. This required VV ECMO. This was not a cardiac involvement. This remained on ECMO for almost 2 months, and he recovered. We did not do it, but when he uh, went back to Canada, they did his COVID titers. It was pretty positive. So possibly that was the first case in the country itself. Generally, nobody did ECMO at that time.
Great, sir. Thank you for the answer. So I think that is about all. So I just want to inform the audience that sir has one of the pioneers in the use of VA ECMO in the country for aluminum phosphide poisoning. That is a very deadly poison with no it had almost 100% mortality till he started using VA ECMO, and he had wonderful results. So just wanted to share with you, and everybody should be using VA ECMO for aluminum phosphide poisonings. It gives very good results, and of course, other poisoning also wherever the cardiac function is compromised. Okay, sir, Dr. Gupta, sir, thank you so much, and thank
Thank
the
you very
audience.
much.
Good night to everybody. Thank you, everybody.